Hey, welcome back. This week we are going to talk about the medications in drug exam number 9. Now, this is the first of two videos where we talk about medications that are given for poisonings and toxic exposure. There are several medications that we're going to talk about, and each of them work in a specific way for a specific problem. The first one we're going to talk about is Sinokit. Sinokit is a antidote for cyanide poisoning. Now, if you watch James Bond movies, you probably think cyanide poisoning that is something you are going to see quite often, but that's actually not the case. When we talk about acute cyanide poisoning, we're not thinking of that classic spy versus spy assassination attempts. We're talking about cyanide that is in nature. For example, there are apple seeds have cyanide in them, but typically you'd have to eat and consume a lot of apple seeds for this to become a problem. Where we typically see cyanide poisonings in patients that have been brought out of house fires because cyanide is a byproduct of combustion. Now, what a cyano kit really is just the vitamin B12. And that vitamin B12 binds with the molecules of cyanide and turns them into a non-toxic substance that the renal system that can then get rid of. Now, it's important to understand that cyanide is a poison that affects oxygen consumption at the intracellular levels, so it can kill very quickly in high doses, especially. Now, the dose for the Sinokit is 5 grams given in an IV infusion over 15 minutes at a rate of 15 milliliters per minute. And that typically is a max dose of 2, max dose being 10 grams. All right, the next medication we're going to talk about is good old activated charcoal. Activated charcoal is exactly what it says it is. It is literally produced by grinding up uh, charred wood in making it into a liquid suspension. And the patient is made to drink it or it's given via a G tube. So how it works is that it binds with the other elements that are in the stomach. So to help bind those toxins with the glucose, or excuse me, the charcoal, and then it will be passed out. If you've ever seen activated charcoal, it is as black as night, and it is very messy and it stains everything it comes in contact with. Now, the big risk with activated charcoal is the risk of aspiration. So we don't see it as much on the ambulance as we used to. A lot of times you'll see it given in the ER, and it can be a quite messy situation. But hopefully that charcoal will absorb with the poisons that are in the stomach, and then they'll be passed out naturally. And typically it's given 25 to 100 grams, given either orally or via a G tube. Acetylcysteine is the next medication we are going to talk about, and it is better known as Mucomyst. Mucomyst is a medication that we give for Tylenol overdoses. You'd be surprised the number of times that we go to potential overdoses that are related to Tylenol. Now, we're not talking about I was supposed to take 1 gram of Tylenol and I took 2 grams instead of 1. We're talking about patients that are taking 30 or 40 grams of Tylenol in an attempt to harm themselves. Typically, we will give 150 milligrams per kilogram of Mucomyst IV. Usually it's mixed in 200 milliliters of DW and infused over an hour. Not something we see a lot of. It's given more in the ER and than what we typically do. It is also been known to exacerbate asthma, so that's something that has to be monitored closely because it can cause bronchoconstriction. The next medication we're going to talk about is Narcan. Narcan is also known as naloxone, and we know that it is a competitive blocker for opiates. So it will counteract the effect of opioid overdoses. When I talk about opioids, I mean heroin, fentanyl, morphine, hydromorphone, all those different types of traditional narcotics that we think of. Now, as a paramedic, we have to remember that we need to be good EMTs before we are good paramedics. Now, you will see a lot of people carrying Narcan, naloxone that are just lay people, police officers, that type of thing. So a lot of times somebody will have been given Narcan before we ever get on scene. We've seen it given to stroke patients. We've seen it given to diabetic patients. That happens quite frequently. Someone finds somebody unresponsive and they give them a huge dose of Narcan. And that's great, because if it is an acute opioid overdose, it will positively affect them. But I want you to take a moment and to think about this. When we have a patient that has overdosed on fentanyl or heroin, the problem is not that they have altered mental status. The problem is that they have respiratory depression. They're not breathing adequately. So for a paramedic, if you find yourself presented with a patient that has respiratory depression, shallow respirations, slow respiratory rate, your first treatment is not Narcan. Your first treatment is to open the airway, assure it is open, and provide ventilatory support. So you start bagging the patient, someone grabs the Narcan, and then you give the dose of Narcan. You don't want to let them sit there in respiratory compromise while you're digging through the bag to get out your Narcan. Your first step is to control their airway and to bag them until you're ready to give the Narcan. Now, the adult dose for Narcan is 0.4 to 2 milligrams given IM, IN, IV, IO, or even ET, down the ET tube. So that's a lot of options. Most of the time now, we see it given intranasally, and that's great because it works quickly. But with intranasal administration, you don't know how much the patient is actually given. So typically what we do, if let's say we decide that we're going to give them 0.4 milligrams of Narcan for a suspected opiate overdose, we're going to give half of the dose in each nostril. So if, for example, we're going to give 0.4 milligrams, we're going to give 0.2 in one nostril, 0.2 in the other nostril, because that by using both nostrils, we get deeper into the structures within the nose, and we get quicker absorption of the medication. Now, Narcan is great, but we need to reverse the effects of the narcotic. But we don't necessarily need to wake this patient up completely. What we don't want to do is walk in and give this patient 4 milligrams of Narcan and they go from respiratory depression and unresponsiveness to kicking, fighting, and screaming. So what I like to do is initially, like I said, provide airway support, provide ventilatory support, and then give them 0.4 or maybe 0.8 of Narcan, and then get them to where their respiratory drive comes back well, and then transport them. But then, because then you're not fighting them. Another real issue with Narcan is it a lot of times causes projectile vomiting. And it doesn't do it in a minute. It takes like 10 minutes for this to hit them, and it hits them like a hammer. They go from not being nauseous at all to vomiting huge amounts. So be very cautious of that because that does happen. The next medication we're going to talk about is calcium chloride. Calcium chloride can be given for several things, but we're going to talk about it today as a medication for calcium channel blocker overdoses and for hyperkalemia. Hyperkalemia being high potassium levels. Typically the dose for calcium chloride, that's an electrolyte, is 500 milligrams to 1,000 milligrams of a 10% solution given in an IV push. It also does have a positive inotropic effect. Remember what inotrope means. It means it increases the contractility of the heart. It makes the heart beat harder. It doesn't necessarily have that positive conotropic effect being the patient, their heart rate increases. It is typically more of a antidote for calcium and beta blocker overdoses. That's what I have for you for today. If you have any questions, please hit me up in class, and we will see you in the next video.